In this lecture we're going to look at assessing and managing the airway in a systematic fashion. Now, airway management is obviously very important. Without airway management, the patient cannot be ventilated and will not be able to survive. And it's important to assess how the airway is now and of course how the airway may be in the near future. This poor patient has been subjected to facial burns, and on admission to hospital they were talking and thus had an uncompromised airway at the time, but as the resuscitation continued their airway became very swollen and they needed to have urgent airway management. You can see they have an endotracheal tube, a hard collar fitted and a nasogastric tube inside you. There's also a central line escaping from the top of the hard collar on the left there. Now, airway management. Really, we're going to use all of our senses to assess a patient's airway. If the patient is conscious and they're talking to us, we can assume for that moment in time that their airway is patent, but remember that it may become compromised in the future due to the nature of their injuries, for example, burns or anaphylaxis. Remember to look, listen and feel as we saw in basic life support. So talk to the patient, have a look in their mouth, see if they're shifting air. Hold your face down to theirs and look at their chest, expose their chest, look, listen and feel for breaths. See what the nature of the breathing's like. You may have to open the airway at this point using a jaw thrust, and always remembering the cervical spine when you are opening a patient's airway. Open the airway, look, listen and feel to see if they're shifting air adequately. Always remember the cervical spine in trauma, and if need be, have an assistant perform inline immobilization whilst you assess the airway and place a hard collar if necessary. We'll be able to do this in the skills day in due course. And now might be about the time where you need to attach a saturation monitor and see if you can do an effective assessment of their airway. Anything you find, you treat an airway and you move down a stepwise airway management to try and secure a patient's airway. They may be conscious and talking. For that point in time they have a secure airway. Following that, you could look at head position, assuming there's no cervical spine injury. If you're still having difficulty securing an airway, then a jaw thrust may be an option for you. Following a jaw thrust, if the airway is still not secure, you can try an oropharyngeal or a nasopharyngeal airway. If the patient's still having difficulty with their airway, you move to a bag valve mask. If the bag valve mask is unsuccessful, you can use that in conjunction with an oropharyngeal airway to see if you can secure an airway. If you're still struggling with the bag valve mask, then you might consider inserting a laryngeal mask, and we'll go into that sizing and skill on the skills day. If the laryngeal mask has failed, you may consider endotracheal tube, and failing that, then there may be a surgical airway. Maybe a surgical airway that needs to be performed. Sizing and placing laryngeal masks and sizing and placing endotracheal tubes will be discussed shortly, and it will also be practiced during the skills day. The oropharyngeal airway is a very useful airway adjuvant. It's freely available in most clinics and they're color coded. It's easy to size from the incisor teeth to the angle of the mandible. This ensures correct placement over the tongue down into the pharynx. The oropharyngeal airway can be placed upside down and rotated into the airway, or simply placed over the tongue whilst pulling down the jaw. A nasopharyngeal airway is measured from the nose to the tragus of the ear, or typically as about the same bore as the patient's little finger. We'll practice placing this on the day. A correctly sized bag valve mask will go from the bridge of the nose to the crease of the chin. A bag valve mask is often much more effective in conjunction with an oropharyngeal airway. Laryngeal masks are sized based on the patient's weight, but as a rule of thumb, a size 4 laryngeal mask will suit most adults and a 2.5 will suit most children. We can practice this skill on the day. endotracheal tubes. A 7.5 will suit most adults, and there's a formula to help you size children's endotracheal tubes. This formula is age divided by 4 plus 4. So for example, if it was a 3-year-old, it would be 3 divided by 4 plus 4, which is 4.5 or 4.75. We're going to go back and have a look at that stepwise airway management once more. Nobody should be reaching straight for a laryngoscope and an endotracheal tube in an emergency. Remember your stepwise airway management. Head positioning, followed by jaw thrust, followed by an oropharyngeal or a nasopharyngeal airway, followed by a bag valve mask ventilation, finally placement of a laryngeal mask, failing that, attempted endotracheal intubation, and failing all of these steps, an emergency surgical airway. Always, always, always remember cervical spine management when you're managing an airway. If you suspect trauma and cervical trauma, inline immobilization immediately by a member of your team whilst you manage the airway, and size and fit a hard collar. The hard collar sizing is from the angle of the mandible to the nape of the neck, as you can see in the diagrams on this slide. And for a child, this looks like 3 fingers or 6 centimeters, and that's a correctly sized and placed hard collar you see there. We'll practice this on the skills day. There's a video coming up shortly for an emergency cricothyroidotomy, and we can discuss this more when we see you. Okay.